All right, we'll get started as the last few folks join us this afternoon. Hello, everyone. Welcome to Fighting for Safe Access in a Masks Optional Healthcare Environment, a workshop on making reasonable accommodation requests under the ADA. This workshop is happily presented by DREDF, the Disability Rights Education and Defense Fund, by Senior and Disability Action, and by the Center for Independent Living. We're really happy that you all are here with us today. I would love to introduce our speakers for today's workshop. I'll start with myself. Hello, everyone. My name is Emma Martin. I use she, hers pronouns, and I'm the Community Engagement Program Manager here at the Center for Independent Living, which is a cross-disability advocacy and direct services organization serving Northern Alameda County. As a quick visual description, I'm a white person with short brown hair. I'm wearing a colorful cheetah print top, and I have a black N95 mask on as I'm in our office today. Next, our next presenter is Beth Kenny. Beth uses they, them pronouns and is a member of Senior and Disability Action. Senior and Disability Action is a member-based organization here in the Bay Area that mobilizes and educates seniors and people with disabilities to fight for individual rights and social justice. And then we also have our final presenter, Claudia Center. Claudia uses she, her pronouns and serves as the legal director at DREDF, Disability Rights Education and Defense Fund, which is a leading national civil rights law and policy center directed by people with disabilities and parents who have children with disabilities. As a quick roadmap for today's workshop, we'll begin by discussing COVID mitigation measures in healthcare, kind of from a history to present. We'll discuss the impact of the current healthcare environment on patients. We'll then move into a discussion about the Americans with Disabilities Act and disability rights, as well as all things reasonable accommodations and how to make a reasonable accommodation and sample language around those accommodations. We'll end with touching briefly on some next steps and options if your reasonable accommodation request is denied, and then leave ourselves a good amount of time for questions and answers as well.
Okay, so yeah, this is Claudia Center. I don't know if my video is visible, which is fine either way. I'm a white woman over 50, and I sometimes wear glasses, although I'm not right now. And I'm going to do a short review of COVID mitigation in the context of healthcare, where we have been during the pandemic and where we are today. Next slide, please. Okay, so we have the federal public health emergency and then California's COVID-19 state of emergency. And these two events and the different public health orders that went along with them really dictated a lot of the mandates that existed in healthcare facilities statewide. So the federal public health emergency began January 31, 2020. We had a COVID state of emergency also beginning. And then we have the ending of these emergencies for the federal side, May 11, 2023. For the California side, February 18, 2023. And then in California, on April 3, 2023, the mask mandate for high-risk settings like healthcare, what we're talking about today, ended. Also, around the same time, on May 11th, 2023, CDC, the Center for Disease Control and Prevention, stopped calculating COVID-19 community levels, which are often the means by which entities decide whether to use COVID mitigation measures. Next slide, please. Okay, so this is the important, here on this slide, we are talking about the California Department of Public Health, March 3, 2023 guidance document on masks. And there's a link that you will get when we share the slide deck with everyone. The mask mandates ended on April 3, 2023, the statewide mandate for healthcare facilities. It does say in this guidance document that masks are recommended or strongly recommended in high-risk settings like healthcare based on community COVID levels. But as we just noted, CDC is no longer tracking that. Next slide. Okay, so another source for statewide masking requirements comes from Cal OSHA, Occupational Safety Health Administration. So we have two links here from the Cal OSHA Authority. One is the June 2023 California Workplace Guide covering healthcare. And this workplace guide says that surgical masks, those are masks with ties, or procedure masks, masks with ear loops, should be used for source control. And what source control means that it should be used on people who are symptomatic with something that is contagious. And the healthcare facilities must follow the CDC respiratory hygiene rules. And that means that healthcare facilities must offer masks to persons who are coughing and must advise healthcare personnel to wear surgical or procedural masks when examining a patient who has symptoms of a respiratory infection. And so this is another authority for masking. Next slide. So even though there is no longer a statewide masking requirement in healthcare for California, local practices do vary. And we have some examples here on the next few slides. This is not a comprehensive review of local exceptions in California, but just to give you a sense. So San Francisco County, as of today, which is June 27, 2023, San Francisco County still requires that people who work in healthcare settings wear a mask when around patients. So for example, San Francisco General, which is our large public hospital, masking is required for all patients, staff, and visitors in all areas where patients are present. So that's one example. Another example is Santa Clara County, which requires masking in healthcare settings during, quote, designated winter respiratory virus period, end quote. So it's another local practice that varies. Next slide. Alameda County and Contra Costa County are still requiring masking at skilled nursing facilities, or SNFs, nursing homes. Los Angeles County is a lot like San Francisco County in that they are still requiring masking in all patient care areas. Cedars-Sinai has the signs up throughout its hospitals that say masking is required in all patient care areas and anywhere a patient can be anticipated, including lobbies, elevators, and waiting rooms. Next slide. So these are some takeaways that we want to share from the history and present of mask mandates in the state of California. The takeaways are most state mask mandates are over, but the existing guidelines show that masking is feasible, that masking is recommended for many settings, and that masking is still required in certain circumstances. For example, Cal OSHA requires masks for source control for an infectious person. And so these principles related to masking really help to strengthen and underpin the right to request masking as well as other COVID mitigation measures as a reasonable accommodation under the ADA. And that's why we reviewed these principles. Next slide. Okay, I'm now going to pass to my colleague, Beth.
Thanks, Claudia. So I'm gonna cover the part about impact on current healthcare environment on patients. I am an immunocompromised person, so I can speak from personal knowledge and knowledge that I've gained from people who are in similar circumstances, and share with you some of the impacts. Can you give me the next slide, please? So vaccinations do not prevent COVID infections, and they do not prevent all severe outcomes from COVID infections. We know that vaccinations can reduce your chances of a severe infection and can reduce your chances of long COVID, but they do not prevent the initial infection the way we had initially hoped. And there are many people, including myself, who cannot garner protection from a vaccination. As an immunocompromised person, I've been involved in studies where they've seen what sort of autoimmune response and antibodies my body produces, and it just doesn't produce enough to garner any protection from the vaccines, despite having many. I'd also like to add that some of the tools that they say we have are no longer available, like EvoShield for people who can't garner the protection from the vaccines. That tool has been removed from the market, so it was found to be ineffective. And then one other thing that I hear often is one-way masking. If you want to be protected, just protect yourself. Well, one-way masking doesn't prevent all COVID infections. You know, we have several members of an SDA who have experienced becoming infected while wearing an N95, but being in indoor circumstances where others were unmasked. So when we talk about an N95 as being the gold standard of masking, it is a great tool to have, and it ideally would prevent 95% of the things in the air from getting into from being ingested in, not ingested, but from prevent 95% of airborne infectious things coming into your system. But that's if you have a N95, the correct one, that's been fit tested. People who work in medical and scientific labs where these are required go through a fit testing process. And that process is only available to those folks. We've talked to California Department of Public Health about trying to make it available for people who are high risk, but currently it's only available for people who are in the healthcare and scientific or industrial fields that require that level of protection. So when you say you have an N95 mask, you're hoping you get 95% protection, but that's if your mask is fit perfectly and you don't know. And most of the folks that I've talked to who have been through the mask fitting test process have been surprised at the one that actually fit them. It was not the one that they would have guessed. So that's something to keep in mind. But certainly the mask levels, N95 is the best mask available to us right now versus the surgical masks and that's Claudia was discussing under the OSHA standards. The N95 will definitely provide you a higher level of protection. And then there's other folks in our community who can't wear masks, whether it be for sensory issues or they have a trach or whatever. They physically are unable to wear a mask. So some people are unable to wear a mask or wear them reliably, and those circumstances have to be taken into account as well. I know for myself personally, when I go in for procedures, they often have to take pre-procedure medicine. Even if it's an infusion, I'll have to take medicine that requires me taking my mask off. If I'm going in for any sort of larger procedure that involves sedation, certainly have to have my mask off then. So I'm unable to protect myself, like many of us are unable to fully protect ourselves by just simply one-way masking. Next slide, please. So yeah, again, Peter Chin-Hong wrote, no face mask provides 100% protection. And that is for people who have been fit tested, as well as those of us who haven't. You know, obviously, if you've been fit tested, it's a lot higher protection than what you'll see without it. But again, the N95 is our best mask out there at this point. How this impacts us is the lack of having to think about all of this makes, in all of these circumstances where you could run into people unmasked, when you're trying to access healthcare safety, makes it very stressful to access healthcare, to figure out how you can access healthcare, to be in a healthcare appointment. And it is hard to communicate and hard to hear what you're being told, and hard to get accurate levels. Like, I know my blood pressure is very subjective to stress, like many folks. So it's hard to know, it's hard to get your accurate assessments, and it's hard to participate fully in your appointments. And next slide, please. One of the things that many patients, many people who are high risk are dealing with is trying to figure out whether to delay, what is more risky, delaying necessary care or avoiding the care and risking or delaying or avoiding the care versus accessing care without mandates in place, and knowing that you're going to be exposed to a airborne infectious disease that is currently the third leading cause of death in our country, and that for many of us are at disproportionate risk for. And that just doesn't seem like something that you should have to assess as a non-medical, just patient person. And it's a lot, and many of our conditions, like my own, is impacted by that stress and impacted by that not knowing of, do I need to get that lab work done? Do I need to have that preventative cancer check that I'm supposed to have? Do I need to do this? And delaying care, we know comes with, and avoiding care, we know comes with lots of health complications. So it's very isolating. It's very stressful, and you're very left on your own to kind of make these decisions. I have not been inside in any places other than healthcare facilities during this pandemic, and now that's the one place that's gone, and I'm not alone in that situation. I don't. There's no medical or infectious based control measure that says removing masks is okay at this point. We know it's going to increases infections. We've seen it at Santa Rosa Kaiser. We've seen it now going on in Beth Israel Hospital in Boston, where now they're calling it a COVID cluster happening in the hospital. And they're trying to say, well, we've put everybody in the same room, in the same floors, but then what happens when the staff leaves that floor and they take off their masks and you're riding in the elevator with that person? We're not making policies based on science. And so we're having to kind of fill that in and think of creative ways to keep ourselves safe and assert this is part of what this webinar is to assert our federal rights to access healthcare safely. Next slide, please. So yeah, there are many folks out there who are experiencing this, and it's impacting us as patients, it's impacting the healthcare workers. We have a healthcare worker shortage now, and continuously exposing them to an infectious disease or infectious virus that is doing such damage is gonna make it harder to have healthcare workers and access healthcare. And it's also really changed my relationship with my doctors, knowing that they're willing to, as part of a system, the system is willing to let us be exposed and let us become infected and let us become more disabled and let preventable deaths occur for unknown reasons, really. And it is a betrayal, like this article says, it is a betrayal. Next, I think that's the end of my section, and I'm going to pass it back to Claudia.
Thank you, Beth. I want to just acknowledge that this is a painful experience and a painful time for the disability community. And we're going to be talking about things as lawyers now. Beth is a lawyer, I'm a lawyer, how to maybe resolve your personal situation, and that may help people in our community and on this webinar, but that doesn't eliminate the hurt and sense of betrayal that people are having. So I just want to acknowledge that. Next slide. So there are a number of disability rights laws in healthcare that cover a disabled person as a patient or a visitor to a healthcare facility. Really, you only need to know about the ADA, because the ADA is going to cover all public and private healthcare facilities. But I'm going to give you a few additional laws just so you can feel like you really know what laws cover what types of healthcare providers. So if it's a state or a local healthcare provider, so like a government healthcare provider, it's going to be covered by Title II of the ADA. And that's the part of the ADA that covers state and local government. It's also going to be, that facility is also going to be covered by Section 504 of the Rehabilitation Act, because those entities receive federal financial assistance, typically through Medicaid, Medicare, and other grants. Also covered by Section 1557 of the Affordable Care Act, and state law, it would be Section 11135 of the California Government Code. Next slide. Private healthcare providers are covered by Title III of the ADA that covers essentially private businesses open to the public, to just use a shorthand, and then also covered by Section 504 of the Rehabilitation Act, Section 1557 of the Affordable Care Act, and California's Unruh Civil Rights Act, which is sort of our analog to Title III of the ADA. Next slide. Okay, what do these laws require? So this could be an entire law school class, and this is really just a high-level summary. But these laws require equal access to programs and services for people with disabilities. And equal access includes equal safety, equal risk, that kind of quality. The laws require reasonable accommodations, sometimes called reasonable modifications. They're both legally accepted phrases, where necessary to achieving non-discrimination. unless the covered entity can demonstrate fundamental alteration, which is a very high level of a burden. And it also requires no interference or retaliation. So you're not supposed to be treated badly because you try to assert your rights as a disabled person. Next slide. Okay, so what is a disability under the ADA Amendments Act of 2008? Hold on one second. We probably know the definition because this definition has been often shared in webinars that members of our community have gone to. But disability under the ADA is a mental or physical impairment that substantially limits one or more major life activities. So that's been the standard definition since we first started having disability rights laws in 1973. So under the ADA Amendments Act of 2008, substantially limits was redefined, or we got new rules of construction that allowed there to be much broader coverage of disability than what we had before this amendment. So substantially limits is now construed to not be a demanding standard, to no longer consider mitigating measures. And mitigating measures means things like medications or prosthetic devices or adjustments that a person makes to mitigate the symptoms of their disability. And so, so that means, for example, if you have diabetes, but you have a lot of devices that help you maintain your blood sugar and insulin, even if you're doing really well on a day-to-day basis, you're still disabled, because what the ADA Amendments Act of 2008 says is that you consider the person as though they're not using any of those devices or measures to maintain blood sugar and insulin at the proper levels. So that encompasses a lot of disabilities. You also consider the condition in its active phase. So even if it's a condition that goes in and out of remission, or a condition that's episodic, like migraines, MS, all kinds of psychiatric disabilities, you consider the person when their condition is active. So for example, seizure disorders, you consider it when the person's having a seizure. So of course, in that situation, the person is substantially limited in major life activities. The major life activities prong of the definition of disability was also amended and expanded in 2008. So there's a long list of functional major life activities, and then there's an expanded concept and list of major bodily functions that are now sort of blessed and permitted to be used as major life activities. Next slide. Okay, so I'm not going to spend a long time on this this slide. This is a list of some of the functional major life activities that count under the ADA as amended. But you'll get the slides after this presentation, but just to note that there's a long list of functional activities that count as major life activities, all the way from performing manual tasks to eating, to thinking, to concentrating, to interacting with others, and so on. Next slide. And here is a slide that lists a long list of major bodily functions that also count as major life activities. And so the immune system is one. So a lot of people who have disabilities that are vulnerable to COVID-19 or to other infectious diseases, the immune system, major life activity may be of interest. Next slide. There is also the concept after the 2008 amendments that there's predictive assessments for certain types of disabilities. And this is a concept from the EEOC and DOJ regulations. I have the citations there. Oh, actually, the citations I have here are only the DOJ citations because we're talking about healthcare, but it's also true in employment. So there are conditions that are virtually always disabilities because of the way that the condition inherently limits major life activities. And so this slide lists the conditions that are virtually always disabilities, including, I'm not going to read them all, but things like deafness, blindness, intellectual disability, using a wheelchair, autism, cancer, and so on. And you'll have the slide deck that you can read. Next slide. Okay, so here's the takeaway that I want you to have is that disabilities can include a broad range of conditions. So, you know, we had a long period before the ADA amendments of 2008 when every court case was a struggle around who had a disability, but that's no longer our reality. So in our current situation, disabilities can include psychiatric disabilities like PTSD, bipolar disorder, schizophrenia, depression, anxiety, OCD, traumatic brain injury, intellectual and developmental disabilities, autism, neurodiversity, mobility disabilities, being deaf or being blind, learning disabilities, ADHD, dementia, Alzheimer's, and chronic illnesses, including things like diabetes and long COVID. So that's the big takeaway, is that the definition of disability under the ADA is broad. Next slide. Okay, so when we're talking about making a request for reasonable accommodation, what courts will look at and what covered entities will look at is what is reasonable. And reasonable is not defined in the statute or the regulations, but the courts will look at, when considering what is reasonable, they'll look at, is it feasible? Is it ordinary? Is it something that's ordinarily done? And they'll also think, well, even if it's not ordinary, is it justified given the circumstances? So here, I think that we can make strong arguments around masking of everyone being present at an appointment to be reasonable. And the reason I say this is that we know that masking is still required in some jurisdictions, including not just of healthcare providers, but of all people present. So we know that's true, at least in San Francisco. We know that it's still required statewide in some circumstances under Cal OSHA. We know that it's feasible as demonstrated by past and present experience. And we can say that the modifications justified given the circumstances, which include for immunocompromised people and people with other disabilities, the risk of severe health outcomes from acquiring COVID-19 or other dangerous infectious diseases. Next slide. Okay, so what are some of the possible reasonable accommodations for mitigating infection risk in healthcare? So we've been talking about masking of people during the appointment, which is a very important accommodation and probably the top accommodation that people need and ask for, but it's not the only accommodation that you should keep in mind. So this slide lists video telemedicine when it's appropriate as a way of accessing healthcare without infection risk. the masking of staff during time at site, the masking of all people in the environment during time at site, increased ventilation at the site. So for example, air filters or an open window, separate space for waiting on site. So waiting in a separate room so that you're not near members of the public who are not masked and who may well be infectious. Waiting in a car or outside until the appointment begins. So in other words, having a protocol or a change in policy that they'll call or text you to have you come in so you don't have to be around other people. Referral to a different healthcare facility that does have COVID protocols, because healthcare facilities can themselves require masks, even if their state or local government does not. It's also possible for some appointments to happen outside or at the person's home. Obviously, those are less ordinarily. Remember the slide where I talked about ordinary? Those are a little bit less ordinary. So you'd have to justify those given special circumstances, but they're still feasible. They're things that could happen. Next slide. Okay, so this is still me. I'm going to be talking about how to make a reasonable accommodation request. One moment. Next slide. Okay, so I'm just going to go over some basics about how to make a reasonable accommodation request. So the first thing is you want it to be in writing. You want it to be in a writing where you end up with a copy. So it's fine to use the telephone if that's part of, how you're going to get information and have some back and forth and do some investigation. The telephone is a great tool, but you want to confirm your request in writing, either by email or through the healthcare portal. Take a screenshot. Just make sure you have it on your end in writing in some way. If you're using the email, making a request by email, you want to cast a wide net, because it's not always clear, particularly with private healthcare entities, it's not always clear who's the right person to take your request. Private entities aren't required to sort of have their staff lists online in the same way that a public entity might have to be more transparent. So you're going to have to do some Googling and some investigation and try to include people like the patient coordinator, the ADA coordinator, the appointment coordinator, and also any kind of supervisor, administrator. Just try to get people that you think have some kind of power over policies and procedures. If your healthcare system doesn't really do email, but instead directs you to a portal, in that portal, you want to be specific, so to kind of flag for whoever sees your portal message that you're requesting a reasonable accommodation for a disability. And in that portal request, ask for instructions. Just say, if this is the right way to do it, great. Or if you need me to go somewhere else, let me know. Just make it, put the onus on whoever's reading your message to respond. Next slide. Okay, so the core elements of a request for reasonable accommodation is, first of all, to identify yourself and state the conditions that create the vulnerability, and briefly explain why the condition is a disability under the ADA. So really, as you could see from the ADA Amendments Act of 2008, you don't need to focus so much on whether your condition is a disability under the ADA. Really, the issue for these modifications are that you need the reasonable accommodation, and that the entity should implement the accommodations you need because it's feasible, reasonable, ordinary. Okay, so the first element is disability, that you have a disability. The second is that you need reasonable accommodation, that you need reasonable modifications to mitigate the risk of transmission of COVID or another disease. And in this, we're going to get into a little more detail on this, but here you want to explain the connection between your disability and why you need to mitigate risk. And then to state the particular accommodations you are seeking, identify what you're asking for. And then the last piece, now this isn't 100% required, but it'll make your request stronger, is to make it clear that you're willing to communicate. You're willing to discuss your requests, provide information, consider alternatives. Next slide. So here's some additional helpful elements that might make your requests for reasonable accommodation more persuasive. First, if you have a prior experience where you experienced severe effects from COVID-19 or another illness and suffered harm, for example, if you missed a substantial amount of school or work or had a permanent injury or anything really harmful, which those are all very harmful things, you could describe that experience to say, I've previously had COVID-19 or some other infectious illness and became ill for X days, X weeks, and it caused this harm. That would make it more persuasive. Another prior experience you might want to include is if you were forced to be in a risky setting for a necessary appointment and you experienced disruptive fear and anxiety. Say you tried to go to a healthcare appointment or another important appointment and were unable to complete the appointment because you had a panic attack or your blood pressure went up and they were unable to get, for example, a clear reading. And then another personal experience that might be relevant and persuasive is if you had a prior experience in which you were accommodated for an appointment, you showed up, it was really easy, everyone found the accommodations to be feasible and appropriate, and it was no big deal and a success. Those are some elements that are additional helpful elements to be persuasive with healthcare entities. Next slide. Okay, so here's some sample text for the reasonable accommodation request for a pre-scheduled appointment. So this sample introduction of yourself and disability says, "Dear, patient coordinator Smith, I'm a patient at healthcare provider. I have several conditions, including diabetes, that put me at risk for severe outcomes from COVID-19. And then you can include a link to, here it's to the CDC, but to something that explains the link between risk and your disability. As you likely know, diabetes is a disability under the Americans with Disabilities Act because it substantially limits several major life activities, including the endocrine function." So that's just an example. Yours doesn't have to look exactly like that, but just introducing yourself, your risk, your diagnosis. You don't have to necessarily give chapter and verse of your diagnosis, but some name of your condition and why it's a disability under the ADA. Next slide. Okay, so here, the next piece is your statement of why you need the accommodation. So here, the sample statement says, "I wear a mask to healthcare appointments, but no mask is 100% effective in preventing transmission of COVID-19 or other dangerous infectious diseases. Because of my disabilities, acquiring COVID-19 would threaten my health and well-being and potentially cause great harm. I need and am requesting reasonable accommodations to have an equal opportunity to access healthcare as a disabled person. I am requesting accommodations that will mitigate the risk of my acquiring COVID or another disease while at my upcoming appointment on such and such a date." Next slide. And this is a sample statement of the requested accommodations. This slide includes the request that the patient be permitted to wait in a separate space by themselves instead of in a waiting room with unmasked people, and that providers and staff wear high quality N95 masks while near the patient or interacting with the patient. So that's just an example of the requested accommodations. Next slide. Here's a sample statement of a willingness to communicate. This one says, I think that the accommodations that I've identified are the simplest and most feasible ways for the healthcare provider to accommodate my disability. However, I'm open to a discussion, basically. So that's just an example of how you might include your willingness to communicate. Next slide. Okay, now I get to turn it over back to my colleague, Beth. Thank you, Al.
Thank you, Claudia. So the next section is next steps to take if your request is denied. And this is an important step. Although we have these federally protected rights, many of us are being denied, and it is a process to work through. And so I'm going to talk about some of those. Next slides, please. So one thing that you can do is evaluate and escalate within the healthcare organization. And I can tell you personally, I've had some success with this. I have had where some initial requests denied, and when I went back to the providers and said, hey, these are my federally protected rights, you have an obligation, and let's talk about ways that we can make this work. We've been able to find, with some of them, I have been able to find different accommodations that have worked for all parties involved. For instance, at my dentist and oral surgeons, we have worked it out that I come in before the office is open to the public. And that has been working out quite well for all parties involved. So I think having that open, it's, you know, all of these, each step, it's going to be easier to resolve if you can resolve it with the healthcare provider, because everything takes a long time. And some healthcare providers don't understand what their responsibilities and duties are under the ADA, and they feel they're following the current California Department of Health guidelines and the CDC guidelines, so they're meeting their responsibilities. And so for some folks, it could just take an extra bit of education and reminding them that, hey, I have these rights, I want to work this out with you, let's talk about it. And so I really like that piece that Claudia talked about of in your letter, including being open to ongoing communication with how to resolve this, because this will be your most effective and quickest way to resolve these issues after a denial. And, you know, if it's a small office, you can probably talk to somebody, but you want to, if it's a bigger organization, you want to find out who the highest, like high level administrator is, or that you can talk to another, or contact their general counsel for the health care provider, and let them know that you feel like your rights are being violated under the ADA, and you would like them to reconsider the denial, and that you're, once again, you're open to figuring out a way to accommodate your needs that is reasonable for all parties involved. So if you're looking to find out who the general counsel is for a healthcare provider, you can use the State Bar of California's advanced search function. So if you go to the State Bar of California and do attorney lookup, hit on the advanced search function, and then it will ask for their name, all sorts of different information that you don't need to have. You can just put in under their firm name, the name of the provider. For instance, I did this for Kaiser, and I simply put in the only field that I filled was firm name Kaiser. And I was able to get all the counsel for Kaiser in the state of California. So talk to those folks first, see if you can make progress there. If you can't, then it's time to ask to file a formal grievance and follow through and file that formal grievance. That gives the healthcare provider time to resolve the issue once again. And before you can escalate it, most of the next steps will require you to have filed that formal grievance, unless it's an emergency circumstance. But for the most part, you will need to file a formal grievance with your healthcare provider in order to then, hopefully at that point, you can work with them again and resolve it. But if you can't, you have to then, next slide, please. Oh, this is a, when you're, this is a part, sorry. When you are asking, telling during this stage of when you're asking, elevating your concern within the healthcare organization, a great tool that we have is to tell the healthcare provider about their duties that they have a duty under the ADA, and that they can reach out to the Pacific ADA Center to find out more about what their responsibilities are. We have rights, they have responsibilities that have to be honored under that. And so the Pacific ADA Center issued a statement for us that healthcare facilities like hospitals and doctor's office must follow ADA requirements. Some patients who visit healthcare facilities have disabilities that make them more likely to get diseases that are easily spread, such as COVID-19 or lung virus like RSV. These patients may also be more likely to get very sick from these illnesses or take longer to get better. So the Pacific ADA Center is recognizing that that healthcare facilities need to make reasonable accommodations for people who are at high risk, and for disabled folks who are at high risk when they are visiting these healthcare facilities. Some of the, and so when you're within the healthcare provider, if you can say, hey, contact the Pacific ADA Center, they can tell you more about your responsibilities under the ADA. The Pacific Healthcare Center, Pacific ADA Center rather, has already issued a statement now saying that healthcare facilities must provide reasonable accommodations to protect patients with certain types of disabilities, and the accommodations can include telehealth, a separate space for waiting for appointments, masking by all staff located near the patients, better ventilation at the sites by opening windows, running air filters, and other modifications. So that's the Pacific ADA Center is a neutral party that is there to teach people about their rights under the ADA and their responsibilities. They're not a political organization. So it's a neutral organization that you can send the healthcare provider to, so that they're not just feeling like they're hearing it from you. And that can be powerful, especially because our Pacific ADA Center is now saying we have a right to reasonable accommodations in healthcare, given the right circumstances. Next slide, please. So if you try to work with your healthcare provider and file the formal complaint and you're still getting denied, then you can file a formal complaint with an administrative agency like the US Department of Health and Human Services, their Office of Civil Rights, or California Civil Rights Department. For those of us in managed care, the California Department of Managed Care Healthcare is where you can escalate claims as well. For, believe it's people who are on Medicare or Medi-Cal can escalate their complaints to the California Department of Insurance. But these procedures can be very slow and not often be ineffective. So that's why I'm saying we should try and work with your healthcare provider as much as possible. It may not be as easy as we would like it to be, but it is going to, if you can get, like Claudia said, cast a wide net and get a friendly ear within your healthcare provider network, and get the accommodations that you need, that is going to be the fastest way to ensure safe access within the healthcare situations. These steps will take longer, but it is your right to do that. Next slide. And I think, Emma, were you going to talk about this, or is this my slide?
Yeah, I'm happy to jump in. Thank you so much, Beth and Claudia. Just as we're thinking about some things that might be next after this workshop, we covered so much, and we wanted to have some more offerings after the workshop. And so we have decided, in partnership with Senior and Disability Action and Center for Independent Living, to host a peer support office hour. Peers will be available. So again, not lawyers or legal advocates, but peers will be available to discuss some potential reasonable accommodations, workshop or brainstorm together some sample language, share experiences, and generally support one another with parts of the reasonable accommodation process, because we know it can be tough. Our peer support office hour is currently scheduled for Thursday, July 6th from 12 to 1. There's a registration link on the slide that will be sent out after. I think it'll be easiest for folks to click it when it's sent out afterwards along with the slides. But again, if you wanted to place a hold in your calendars, that will be Thursday, July 6th from 12 to 1 for a peer support office hour. Also, after our workshop today, we're going to send out a survey to attendees just to hear from folks. So many people here have been sharing, in the Q&A or in their registration questions, some of their experiences already sharing their experiences requesting reasonable accommodations in healthcare. And we wanted to send a survey out after the workshop to help our organizations and our communities better understand what type of accommodations are being submitted by our communities, what type of accommodations are then being met or denied or not met, and then where are these accommodations being met or denied by which healthcare providers, etc. So it's a short survey, but I think it'll be super informative for, again, not only our organizations, but also the community to get a better sense of the accommodation and healthcare landscape and some shared experiences from peers. So we will send out the survey after the workshop as well, alongside the other materials. All right. Let's see, it's 1:37. That leaves us, little over 20 minutes for question and answers. We've had so many amazing questions submitted in our Q&A function live during today's workshop. We also had some wonderful questions submitted during registration. And so I'll hop in and present some of these questions, and Claudia or Beth, or if I have anything else to share, we can do that. So one question, if we can start with a question around N95s, and there's a kind of a two-part question here. So someone had asked, if a healthcare provider is denying an N95 masking accommodation, are they required to give you a reason? This person said they have medical documentation for the need for an N95 mask and not just the surgical mask. There was accompanying questions also in the chat about, if a healthcare office doesn't have N95s, could it be an accommodation to ask them to purchase them? You know, some healthcare facilities don't have those N95s. So that is the first question for you all. Happy to repeat if needed.
This is Claudia. Emma, if you want to stop screen sharing, we'll have all the architecture available. Thank you. So I don't think there's a hard and fast answer to exactly how to go about this, other than that the science is really clear that N95 is the most effective mask. And there's many studies easily available out there online that demonstrate that N95 is the most protective. And so if you establish a need for accommodation and the hospital grants your accommodation, then it would logically follow that they should wear an N95. We know that logic does not govern our lives here. But Beth, do you have any, or Emma, any further?
Yeah, no, I would just reiterate what you said, Claudia. And I see somebody saying that their provider is telling them that the latest study says masks don't work. And I know that there was a study out there saying masks don't work, but that study has been very much debunked, the Cochrane study. And not only has it been debunked by the scientific community, it's been debunked by the Cochrane, the people who wrote the studies. So, N95s.
And I would think that healthcare providers, just by definition, should have N95s on site, but if they don't, I don't know if you can afford to bring them. It might be easier, but what have you done, Beth?
I have brought them because I can afford to, and because I don't always trust that they're gonna be there, even if we've agreed to it. So I like to bring it just to ensure that it's gonna be available.
And this is Emma. I'll just hop in super quick. I don't have a full list of resources gathered on this already, but I imagine that there are still community projects like Project N95 and maybe other community organizations that are still distributing N95 masks, and perhaps could gather up a couple of those resources to send out as well, just in case that's a burden for folks to kind of bring their own masks to places. Another question that I saw a few times in the Q&A, and so I wanted to bring up to address with our presenters. We had a question about the disclosure of disability as part of requesting an ADA accommodation, and several folks who said they were under the impression that they didn't have to disclose like their specific disability when requesting an accommodation, and I thought that was important to address.
Yeah, this is Claudia. I'll do a first shot at this. So there are situations where there are very quick interactions between a person with a disability and a covered entity, where the public policy and the law is that you don't have to provide a lot of detail about your disability. You don't have to provide a medical document. So that would be, for example, someone with a service dog entering a private business that typically doesn't allow pets. Because that is such a quick interaction, it's not considered feasible or appropriate to require that the person demonstrate or disclose their disability. On the other end of the spectrum is, for example, when you ask for an accommodation in the workplace. In that context, it's well established that the employer can require, they don't have to require it, but they can require some reasonable medical documentation that generally tells something about your disability and why, because of that disability, you need a particular accommodation in the workplace. So a relationship with a healthcare provider is sort of in between those two poles. It's not like a very brief interaction where you're walking into a store with a service animal, but it's not a day-to-day, day in, day out relationship like you have with your medical provider. So you're asking for something affirmative that you may have some resistance depending on the healthcare entity. You're asking for masking and other steps. So in that situation, I think it's best practice and probably much more effective to say something about your disability, to explain kind of what category it is and why it puts you at higher risk, and then go ahead and ask for the accommodations. I think saying I have a disability, but I'm not going to tell you what it is, but I want you to wear a mask. I mean, you can do that and see if it works, but I think you're going to be more persuasive if you give some background as to why you need the accommodation.
Thank you. Beth, did you have anything else you wanted to?
I was just going to echo what Claudia said and say that, to establish that nexus of need, there are certain disabilities that maybe don't put you at higher risk for COVID. And to simply say you have a disability, people are questioning things right now. They want to question this. This is not something that's going to be welcomed in many spots. And so you want to just establish things as clearly and as you can from the outset. I understand it's difficult to disclose. And that's, something that you have to decide for yourself. But I would say that stating your case and the why you need it right from the beginning really helps set the tone. And I have found that there's a lot, healthcare providers are more receptive to that.
Great. Next, we had several questions submitted during registration and echoed a couple of times in our Q&A around the issue of other unmasked patients in different healthcare settings, and if a reasonable accommodation could, like if other patients can be required to wear masks during in a healthcare setting alongside the person making the request.
So, our point of view and what we're advocating today is that requiring that other people around the patient wear a mask can be a reasonable accommodation. We think it's feasible. We think it's ordinary given, practices during the pandemic and also in, some settings, even pre-pandemic. There are some situations, for example, cancer units or other types of hospital spaces where everybody had to wear a mask even before COVID. So I think that our position is yes, that should and can be required as a reasonable accommodation in order to make it more likely that you'll get the healthcare you need. We've come up with some other ideas, such as that you wait in a separate area, and that, so that if it's not feasible for you to, or it's denied for the other people to be masked, that at least you maximize the amount of time that you're away from those people waiting in a separate space. But yes, we think it's feasible and appropriate to require masks of everyone for your appointment if you're at higher risk.
Yeah, and I would say, again, echoing what Claudia said, it is reasonable, it is following the science, and you might want to include some other ways to make that happen, whether it be having your own private waiting room or private room if you're staying in for a long time, where all staff coming in has to wear masks. It is reasonable to us, but you want to provide your healthcare providers with some other ways that maybe that you could avoid the situation where you're interacting with people who are unmasked.
I'll just add in real quick. I don't know if this one actually made it onto the slide, but one accommodation that we've heard of folks in the SDA, Senior and Disability Action Group, suggest is requesting like the earliest appointment time or an appointment time before the office opens. And so to the general public, I don't know if you all remember, but like also during the pandemic, like grocery stores were doing, just those certain early hours in the morning where people with disabilities and older adults could come in and shop and it'd be less crowded. So members have had success with can I get an appointment time early in the morning before an office opens to the public? Gosh, there's so many amazing questions rolling through here. I had one question submitted around requests in writing, and that a lot of healthcare settings, patients saying that they're wanting to make their ADA, their accommodation requests in writing, but they've been unsuccessful because many clinics and healthcare settings are only accepting faxes, and often these faxes go ignored. And so they were wondering, can I make an accommodation request on the phone? And if so, are there any tips in terms of tracking exactly what happened in the phone call so there's no worry about it later?
Beth, any ideas?
Yeah, for my providers who haven't made an email address available or a way to contact them electronically in writing, I have submitted a fax, called to say that I've submitted the fax, and sent what I've submitted by fax in the mail. And it's a lot, but it's, and I tell them, when I tell them that I've submitted the fax, I'm also dropping it a hard copy in the mail to you guys. So that just anything you can do to not be ignored.
Sorry, it took me a moment to unmute there. Next, we had several questions also submitted regarding retaliation. We know that's a really big topic that, I think could be its own workshop in itself. We had a few questions around folks who have made accommodations and experienced retaliation from their healthcare providers, like even being, discontinued from the practice or from healthcare services. Also other folks who are echoing this question and saying, I'm nervous to make an accommodation request because of potential retaliation. And so we know, kind of what the ADA says and the law says, but wanting to hear from our presenters if you had any further thoughts about retaliation, potential retaliation and retaliation.
I think Claudia, I think this is a really hard question to answer. The law is very clear that retaliation is prohibited, that interference is prohibited. But what happens when you, in fact, encounter retaliation? That's part of why we're encouraging people to be sort of very polite and persistent, because it makes it more clear that you're being retaliated against if something negative happens toward you as a patient following a polite, persistent request for accommodations. You can file a complaint with the entities that we listed before on the slide deck. You can go back to your insurance carrier, Medicare, Medi-Cal, or your private health network and say, I've been dropped by my healthcare provider. I need another healthcare provider. They're supposed to, make sure you have that. I know that's often ignored. We don't have enough providers. Those are some ideas. They're not great ideas because they're not, gonna fix things on any relevant schedule. Beth, what are your ideas?
Yeah, I think if I'm being told verbally that I'm going to be dropped as a patient because I've asked for a reasonable accommodation, this is the point where I'd say, I'm worried that you may be violating federal law. And I suggest you check in with the Pacific ADA Center about what your responsibilities are under the ADA. And then let's talk again soon. Because if they're saying retaliation, you can't have much more of a conversation at that point, but once, and I feel like they may not be aware of there's a chance they may not be aware of that they are violating the law. So, making a simple statement of, I'm afraid you may be violating the law. I suggest you check with Pacific ADA Center to find out what your responsibilities are, could go a long way, but it's not a foolproof method by any means. And I also, if you are a person who has experienced retaliation, I think I don't have a path forward for you, but I would like to know, SDA would like to know more about how often this is happening and where it's happening. And I really encourage you to fill out that follow-up survey that we have, because we don't have data. Not only is CDC not tracking data, we don't have data on how this is playing out. We hear about different things going on in the news, but the news coverage is unreliable as well. So let's start sharing what we know, where our successes are, and where we're really coming up against bad outcomes.
Yeah, and particularly if there is a clear-cut, if you have a clear-cut case of retaliation, I think that this group and others are interested in elevating that probably to the United States Health and Human Services Office of Civil Rights. They have been good on related issues, and we think may be good on this issue. The problem is it's not going to solve your current need for healthcare. So we can pursue that, and we think it's very valuable to pursue that. But in the meantime, you're going to have to figure out where you're going to get your healthcare. So it's not going to be a solution to that.
I think also I wanted to acknowledge, several questions and comments in the question and answer box from folks who have said, who are expressing that they have tried a lot of making different reasonable accommodations and following these steps and tips that we've talked about in the workshop, and that they're still facing, retaliation and denial of accommodations and increased health, safety, and life risk in healthcare, and urging community advocates and national organizations to expand and lift up advocacy as well. Just thinking like, okay, self-advocacy, in the limits of self-advocacy, what can national organizations, what can community groups and grassroots groups, like what can we do in addition to self-advocacy as well? So I think wanting to lift that up. I don't know if either of you had comments to that effect.
Yeah, I have a comment. This is Claudia. So we went through a little bit something like this during the pandemic around the way that hospitals shut down all what they called visitation. And we have patients who are in the hospital who rely on family members for different kinds of communication, supports, and other kinds of supports, self-care supports. This was primarily, and still is, primarily people with significant physical disabilities or significant cognitive and other disabilities. So what we did in that situation is we worked to get guidance out there through the California Department of Public Health, through United States HHS, through other means. We did fact sheets. We finally got DFEH, which is now called the California Civil Rights Department, to do something. So we eventually got enough out there to have that baseline. And then DREDF, my organization, together with Disability Rights California, did a number of limited representation matters where we sent demand letters to hospitals, and in most cases resolved the situation to get visitation granted or access to support granted. So I think that today's webinar is one of the steps in a similar process for this issue. DREDF is open to continuing to work on this issue in collaboration with other legal services organizations, in terms of, providing the self-help tools and then doing some limited representation, particularly to start with large healthcare providers, to try and make this an ordinary, type of accommodation granted. Obviously the healthcare staff is going to be easier than the patients, in terms of the affirmative masking. But so that's what I can say about the future. It's still a bit of a question mark, but that's the model we have from earlier in the pandemic.
And I totally understand where people are coming from as far as like we need to get something going, and we are. I think it's not as fast as any of us would like it, and that's an unfortunate reality of our time. But we do have like dread of being here today and putting on this webinar. We see national organizations getting involved and wanting to be part of this fight for. And so I understand your frustration, and we are trying to do what we can do and as fast as we can get it done. And it's unfortunately just a slow process. And hopefully we're considering having another webinar where we can talk about more about what to do when your accommodation is rejected and those next steps. But we really need to find out what is going on, and where people are at and where they're getting rejected to be able to formulate those next steps too.
Thank you all. And Emma's email has been in all of our materials. And so Emma is well connected to the rest of us, and you can send questions toward Emma, and then Emma will share them and we'll provide answers to the extent we can. Some things are not answerable.
Wonderful. And I just dropped my contact information back in the chat, but we can make sure that everyone can get a hold of me. I've also grabbed some of the questions that came in through the question box that we weren't able to answer during our live portion, so we can discuss how we can best address some of those questions. There's so many incredible questions. Thank you all so much for joining us this afternoon.
Thank you.